Evening, everyone, and I welcome each and every one of you, our audience, and the specialist and array of stalwarts who is involved in retinoblastoma, the most common childhood eye cancer. And that is the topic that we are gonna highlight today. And this is particularly chosen because we recently had the Retinoblastoma Awareness Week, which ended yesterday, and we thought we will kind of sit together as a group, interest group, to talk about various aspects of retinoblastoma. As specialists, of course, we have, advanced a way of thinking what retinoblastoma is and the current management strategies. But this webinar particularly is also, targeting mainly public awareness regarding the disease and how a team of specialists and more than specialists, how the NGOs and other aspects of management facilitates and contributes in improving, various aspects of disease outcome in children with this deadly eye cancer. So I welcome on this outset our extremely prestigious speakers today who consented to take part in this. We have an array of pediatric oncologists, and we have ocular oncologists, and we have other personalities from various aspect of hospital administration and running NGOs for supporting these children. I introduce Dr. Aarti from Shankara Cancer Center, Dr. Mohan Raj from Site Care, Mr. Amit from Site Care, Dr. Meena from Kidwai, Mr. Arvind representing Iksha Foundation for the retinoblastoma in children, Dr. Jitin, Dr. Hridaya from Malabar Cancer Center, and Dr. Sunil Bhatt from Majumdar Shaw Cancer Center. So with this, I'm not taking too much of time. Thank you once again for joining us and accepting the invitation. And more than anything, thanks Microlabs and Microvision for facilitating this and proactively your initiative in bringing this awareness to the public. Thank you so very much. So without taking much time, let us go on to the first, topic of the day, overall introduction of retinoblastoma. And I think Shafali, who's an ocular oncologist at Horus Specialty Eye Care, is the best person to give us an overview regarding what retinoblastoma is and how do we diagnose it, because the title of today's session is Diagnose, Detect, and Defeat. So Shafali, take us through diagnosis of retinoblastoma, please. Thank you.
Thank you so much, ma'am. I'll just share my slides. I hope it is visible.
It is visible, ma'am.
Yeah. Just 1 minute. Yeah. At the outset, I would like to thank Dr. Fairuz for including me in this wonderful session, for having us all together here to create awareness about retinoblastoma. In fact, my journey in retinoblastoma started with her, and I learned so much working alongside her. So thank you so much, ma'am. And I'm here to discuss about retinoblastoma, how to detect it, diagnosis, so that we can defeat this disease. So the brief introduction about retinoblastoma, it is the most common, yes, the most common primary intraocular malignancy in children, which is a potentially lethal tumor. But the good news is that it is a completely curable tumor if detected early. Definitely it presents to an ophthalmologist, but pediatrician's role is so important, and Dr. Meena will be touching upon that, because the frequency of visits of these children, the well baby clinic visit, is so much more than to an ophthalmologist for an eye examination. If briefly we see the global retinoblastoma disease burden in this paper, that it says there are 8,000 cases that happen per year. And if you can see, Asia alone, if we exclude Japan, has 4,500 cases per year. And if we see the global retinoblastoma map, India is at the hotspot, making it the country with the maximum number of retinoblastoma cases. But the unfortunate thing is that only 600 new cases go to the major referral centers, and only about 70% undergo a protocol-based management. So we can see so much more needs to be done to create awareness about this disease, detect it early, treat it appropriately so that we can defeat this disease. And also, if we see the mortality rate, it is so much more higher in Africa and Asia than in the Europe and America. So definitely much work needs to be done, and that's why we are here. Every case of retinoblastoma, as we say, it takes a village to detect it, diagnosis, the expertise, the large heart of the social workers and people involved, and of course the resilience of the parents to make it a success story. And each one of us has to play a role in detecting it early. So that's what I'm going to touch upon. What are the red flag signs that you notice in your child or any child that you seek attention early? The most common presenting symptom is a white reflex. Leukocoria is what we call it, white reflex, leukocoria. And it is the most common symptom and the sign that we notice in these children in about 42% of the cases. We have interesting stories when the mother is the closest to the child. And of course, any abnormality in the eye, the mother can pick up very quickly. And we have had stories when the mother said that I did notice it, but the grandparents said, ki, okay, bacche ki aankh mein chamak hai, or to put it in English, that the child is born with a sparkle in the eye. So he's lucky. So don't bother about it. Let it be. But let me tell you, the child is lucky if you know that there's something sinister going inside the eye and you seek immediate attention. That is when the child is lucky. Another common presenting symptom is squint. Even pediatricians, I know personally, believe that it is only because of the muscle abnormality and needs to be dealt with only at after 3 years of age. But it can happen because something is obscuring their vision. There's something growing inside, and that's why the eye is deviating or tilting. So squint is the second most common symptom that we see. In the advanced cases, we see redness in the eye. When it is too big a tumor that comes out of the confines of the eye, there can be proptosis, which is the bulging of the eye. And if it is too necrotic, we can have orbital inflammation kind of a picture. So all of these symptoms need to be picked up. Of course, if it has spread to the body, it's a cancer. It can spread to the other organs of the body. So child will have failure to thrive, vomiting, headaches, neurological impairment, pain syndromes, and fatigue. Children very seldom complain about anything that is happening to them, and the onus actually lies on the caregivers and the parents and the grandparents to detect this early and to know it. We as specialists, of course, learn about these symptoms, but the question is, as parent or grandparent, it early, do you need any treatments? No, you just need a flashlight, a smartphone with a flash photography. If you flash a photograph the child's eye, you can actually see a white glow. Hence, if you flash the light, spot the white, you can actually save a life. Uh, this is just for the specialists. I put the slide that picture like orbital cellulitis, hypopyon, which can seem like uveitis or glaucoma or ophthalmos, phthisis bulbi even, or unprovocative bleeding inside the eye should actually alert you to refer these patients to ocular oncologists so that detailed evaluation can be done. How do we make a diagnosis? Well, the diagnosis is absolutely clinical, which includes starting from the history. We take a family history, prior treatment history. We do an examination of the child up for the vision and even dilatation in OPD. But children, tiny children, of course, will not cooperate, and hence an examination under anesthesia is required. I've put up a picture of me during an EUA session during my training, and we use cotton buds to actually see every nook and corner of the eye, and hence we need the examination under anesthesia because it is quite detailed. We take the pressure, we measure the white to white diameter, and then we actually make a clinical diagnosis. Of course, we have RETCAM imaging to document these tumors so that we can see the before and after, even after treatment. Ancillary investigations like as simple as ultrasound B scan helps in our clinical diagnosis. It supports us. MRI is indicated to see the extent of the tumor, especially the optic nerve, which is connected to the brain. This is important even to general ophthalmologists who refer the cases. These children have the propensity to develop other tumors also. So CT scan, which has more radiation exposure, should be deferred, and MRI is the favored imaging modality here. After making a clinical diagnosis that yes, that we are dealing with retinoblastoma, we classify the disease. I've just put some pictures, because we actually explain this to the parents too when we diagnose retinoblastoma, because the management depends upon what type we are dealing with, whether they will have retinal detachment when it is growing beneath the retinal layers, or it's jutting out in the vitreous cavity. It will bud out and give us vitreous seeds, whether it's a mixed variety or whether the eye will not do so well if it is a diffuse infiltrative kind. There's another one which is the diffuse anterior retinoblastoma, where the retina might seem normal, but there is a tumor growing in the anterior portion of the eye. We follow the international classification of intraocular retinoblastoma. This also, when we counsel the parents, we actually draw diagrams and show them, because the management, the prognosis of saving the eye, saving the vision depends upon the grouping of the retinoblastoma. We group it into group A to group E, A being the smallest, B a slightly more. I'm not going into the numbers, but C is with seeds, which is quite confined when the tumor has broken down into pieces and the tumor pieces are floating in the vitreous cavity. Group D is diffuse, and E is extensive retinoblastoma. That is what we do after making a diagnosis. Vitreous seeds also, ma'am will be dealing with the management part of it. And when we have an advanced presentation of the tumor, we do go in for a systemic examination by CSF analysis and bone marrow analysis, and then we stage the disease. So not just detecting it early, diagnosing it, and appropriately grouping it and staging it is when our works actually starts for the management. Dr. Sunil and Dr. Feroz will be dealing with the management. I just wanted to put this slide to show the leap this tumor has shown from 98% mortality to more than 98% survival just by early detection, appropriate protocol-based management. And that is why it is so very important in the limited number of years that we have been dealing with this tumor. Again, another slide just to put out there that there are certain conditions called as pseudo-retinoblastomas. This is a picture not of retinoblastoma, looks like it, but it is Coats disease. We have a number of conditions like this which might appear. They might not be deadly, but of course they are vision threatening to the child, and ocular oncologists know subtle signs to differentiate it from the other diseases. So referral should be made to the ocular oncologist who can diagnose it appropriately and manage it. Another very important thing, Hridaya will be dealing with it. Retinoblastoma is a genetic disease, and hence, whenever we diagnose a retinoblastoma, sibling screening is very important. In fact, if a mother is pregnant and they have come with a child who has retinoblastoma, we take in the expected date of delivery date so that we can call them within a week or two to do the eye screening of the child. And of course, childhood eye screening goes a long way in detecting not just deadly cancers like retinoblastoma, but other eye abnormalities. Hence, I would just like to leave you with the fact that early diagnosis, appropriate protocol-based management, and can make a difference in saving the life of these children, the eye of these children, and the vision in these children. That's all from me. Thank you so much for the patient listening.
Thank you, doctor.
Yeah, I think.
Shifali, we can go to the next.
Yeah. So next we have Dr. Meena H with us from Kidwai Cancer Institute, who will be talking on pediatrician's role in screening and referral. Over to you, Dr. Meena. Hi, Dr. Meena, are you there?
Yes, I was thanks. I'll share my screen.
Yes, please.
Dr. Meena is an assistant professor at Kidwai Memorial Cancer Center, and she's a practicing pediatric oncologist. Welcome once again, Dr. Meena.
Thank you. Good evening. Are my slides visible?
Yes, doctor.
The, the topic for me today is the role of a pediatrician in screening.
Ma'am,
Slide is
slides are
not
not visible.
visible. Your pic is visible. I'm
Slides
sorry.
are not visible, ma'am.
Yeah, now.
Share the screen. Down there is a share screen button, green arrow mark.
Green color share screen.
Ah,
Yes. No. Yeah. Can you make it full screen, please, ma'am? Yes, ma'am. Go on.
okay. The topic for me today is the role of a pediatrician in screening and referral of children with retinoblastoma. Retinoblastoma, as we have just seen, is a rare but curable cancer in children, which occurs in a frequency of around 1 in 20,000 children. Two-thirds of these cases are diagnosed before 2 years of age and 95% before 5 years of age. Around 8,000 new cases of retinoblastoma are diagnosed every year, and 85% of these are from developing nations, which are the low and middle income countries. India is one of the top contributors, contributing to about 1,800 cases per year, which accounts for up to 20% of the global burden. When we look at the statistics between developed countries, that's the high income countries and developing countries, this is data from the Global Retinoblastoma Study Group across 150 centers from 300 nations. The average age of diagnosis in developed countries is around 1.5 years, while in countries like India, children present late, around 2.5 years. In developed countries, most of the cases, the cancer is limited to the eye, that is intraocular, in around 98% of cases, while in developing countries, 50% of cases are only intraocular, rest are extraocular. The percentage of cases where the disease has spread to distant organs, which is metastatic disease, is less than 0.05% in developed countries, while it occurs up to 9% in countries like India. The gender ratio is found to be equal because there is no biological preponderance in the any gender, but in developing countries there is male predominance, probably due to gender disparity in seeking healthcare. So, mainly the cause for late presentation is delay in diagnosis, which I'll be addressing in this topic. As we see here, in India, our estimated survival still is around 54 percentage only, where we know it is more than 95 percentage in the developed world. This is some of the data which shows in our country around 17 percentage presence with metastasis at diagnosis, and around 30 percentage of children have there are cases of treatment refusal also. So the picture is not very bright at our end. Okay, so why is this wide disparity between developing and developed nations? Because for any cancer, there is a diagnostic delay which can occur at the patient end or at the primary care physician level. In this case, since most of the cases occur below 5 years of age, most of these children present to their pediatrician. So there might be a second lag period, which is called a physician-induced delay, which might be the delay for late referral to a ophthalmologist. Okay, so this will be I'll be focusing on this delay and how to prevent it. So this is a study which was done in Argentina, which showed that which analyzed the causes of late diagnosis of retinoblastoma. They found that 50% of patients consulted a pediatrician, not an ophthalmologist, but only half of these, that is 25%, were appropriately referred to the ophthalmologist, which is quite unfortunate. And this study also found that the education level of parents was directly correlating with the time to consultation. And a similar study in a country called Honduras showed that simple education program like providing pamphlets to parents during well baby clinics can help patients come up with the symptoms and will also aid in the pediatricians to pick up the findings and refer appropriately to a ophthalmologist for a definitive diagnosis. Okay, as we have already seen how children present in the developed countries, most of the patients present with white eye reflex, squint, and other eye findings. While this data from India shows, due to late presentation, a significant portion, which is 17 percentage, present with proptosis, that is protrusion of the eyeball, which is a late sign. So, what can be done at the pediatrician end? So, as a general pediatrician, all pediatricians should be trained at their course level to be available, to be aware of all the symptoms in which the patient might present, and also this red reflex test It is due to reflection of visible white light by the blood vessels of the retina, which causes the pupil to appear red when examined by of the direct ophthalmoscope. So this picture shows the normal red reflex, and this shows absent red reflex. So this can be, all pediatricians can be trained to use a basic instrument as a ophthalmoscope at all well baby checkups. However, as we have already seen in the previous presentation, abnormal red reflex can be seen in other eye disorders too. So, even then, if it is picked up, it could the child can be referred to a ophthalmologist so that any of these could be vision threatening and could be diagnosed early. Okay. But there are some fallacies in this test. It is found that in 80% of cases, family members detected the white reflex even before the pediatrician. The studies have found that there might be reasons for ineffectiveness of this red reflex testing, which because most of this is done without eye dilation, and we know that most of the cases of retinoblastoma present at the periphery of retina, which may not be so easily detectable. And there could be technical errors in performing the test, and in view of difficulty in examining infants, there might be cases in which the red reflex is missed. So even if the red reflex is not detected, or if there's an issue in this testing, if parents complain of the leukocoria or white reflex, all cases should be referred to an ophthalmologist. There are other few devices which have been designed especially for screening purpose. The arc light, it is a low cost equipment which functions with a solar panel, as we can see in this picture. It can be attached to a ophthalmoscope handle or otoscope and can be used for easy diagnosis of retinoblastoma. There's some other equipments like the portable eye examination kit, which is an adapter clip which can be combined with a smartphone, which can be used to capture training retinal images. This can be done even with supportive staff like nurses, and can be read later by a trained physician. When where facilities exist, devices like the iCam, which is a portable fundus camera which uses IR emitting diode to capture retinal images, which can be forwarded to an ophthalmologist, can be used, but it is not possible in settings like India. There are even smartphone-based applications like the Cradle, computer-assisted detector of leukocoria, where these applications can be used to detect your white reflex. So the importance of early diagnosis of retinoblastoma is vision can be preserved if they are diagnosed early. There can be higher rate of survival, and we can avoid unnecessary acute effects of chemotherapy and also late effects of therapy, and children can have a better quality of life. As a part of our national health mission, the Rashtriya Bal Swasthya Karikram has some job aids for all workers who are involved in screening all children at the Anganwadi and primary school level. These workers are provided with some sheets where they have pictures which they can refer for detecting white reflex and also squint. To conclude, in India, the cause of poor outcome is mainly delayed diagnosis and treatment refusal and abandonment. So, pediatricians, who are the primary physicians of children, can play a major role in early detection, appropriate referral, and also ensuring that once diagnosed, they continue their follow up at oncological center, because many cases of treatment failure are due to abandonment. Thank you.
Thank you so much, Dr. Meena. And I think what you have highlighted here actually weighs the most important aspect of retinoblastoma, how it can be, detected early. And we all say about any cancer for that matter, the best outcome comes when there is early detection as far as outcome in terms of life salvage, eye salvage, and vision salvage, especially in retinoblastoma. Thank you so much for highlighting that. So we have gone across the diagnose and detect part of today's session. I would request our esteemed panelist, Dr. Jitin, who's an assistant professor at Malabar Cancer Center and Postgraduation Research Institute, Telecheri, Kerala, who's doing amazing work in pediatric oncology. He's in fact coming up with a great pediatric oncology and bone marrow transplant unit in that part of India, the south part of India. So, Dr. Jitin, with your experience, with the public hospital setup, I know early detection. You're a pediatrician as well. Starting in your training, early days of training. So, do you think an advocacy to really implement strictly the need for eye checkup and ophthalmological examination in a well baby, regular checkups when a child reaches a pediatrician, do we have any advocacy as such in place at this point of time? And obviously it would help. And how would you think that we can navigate this forward?
Yes. Can you hear me?
Yes, yes.
Yeah. Uh, first of all, let me say there is a heavy rain here in Kerala, so my network is gone, so my voice will break in between. So first of all, let me thank Dr. Fairuz mainly for inviting me for this webinar. And Before going to the question, I'll just give an introduction regarding how our collaboration is working. So, Dr. Fairuz is supporting us in building up our ocular oncology unit at Malabar Cancer Center, and we have been collaborating for the last 5 to 6 years in building up that unit. And I sincerely want to appreciate her dedication, motivation at this time in doing that and coming out here, setting such a unit, because till she joined, uh, such a unit in Kerala was lacking, especially in the government setup. And majority of the kids from Kerala were going outside of Kerala to get the local treatment. And I think things are changing now slowly, but still changing. Thank you, Dr. Fairuz, for this. Okay, coming to your question, yes, definitely some that level of screening can help in identifying these kids early. But the situation is totally different in Kerala. Some of you might know the literacy and education rate so high that most of the kids coming here, the white reflex are found by the parents itself, and they are definitely seeking the treatment very early also. But still there is a gap. There is screening that's still not happening. If you see the Western countries, in US or UK, there is mandatory screening till the 6 weeks of age to look for any white reflex. Of course, not all white reflexes not are retinoblastoma. Around it causes only 1/5 of the white reflex that's a retinoblastoma. But still, we can find almost all these anomalies early, and definitely that can help us in identifying retinoblastoma also. For this, we have been trying to build something like this for last 2 years, especially with the AI coming up and trying giving us new ideas. So why can't we develop such a smartphone app and go ahead with the screening? Because we in Kerala we have an excellent peripheral health infrastructure, especially almost 1 lakh deliveries happening every year, and with a peripheral health infrastructure with ASHA workers functioning very good. So why can't we use this such kind of screening app to screen such of kids coming to immunization and get a hold of all these eye problems early and uh, give them access to care. But once we looked into it, there were many roadblocks that were there, like the cost effectiveness, especially. We need the just not the app, because we need additional infrastructure facilities also that's required for implementing such a screening system. And not only that, even after we find these anomalies, there should be a clear care access pathway to guide them to the second layer. Whichever findings we find, we need to refer them to a facility where all these kids need to be addressed. So uh, ideas are there, but implementation level, there are many roadblocks that's happening. But still there are findings, there are ways we can find alternatives to that. Still working on it, and hopefully we can come up with a better app with newer modalities like AI. I think many such things are happening in China. I think deep learning, using deep learning, newer softwares are getting developed for better sensitivity and specificity. And we can, with a smartphone, every parent can screen their kid's eye and use this and uh, identify this cancer early. Yeah. That's it from my side. Yeah. Thank you.
Yeah, thank you, Dr. Jitin. So my question here is, to have another futuristic solution to it. Do you think the pediatric family and the ophthalmologist family at some point can come together and, approach the government in a larger scale, or at least, the Indian Association of Pediatrics, to actually form an advocacy to start eye screening, particularly in these children? Is it easy? It's feasible, according to you?
No, it's the first step. Definitely, it may be feasible in the long run. Not
I'm
all,
not talking
not all.
about any apps or AI stuff, which
Yeah,
obviously there will be.
definitely. Direct red flag screening, right?
Yeah, like
That's
how
yeah.
Dr. Sinha
Not
indicated. Yeah,
yeah. Not
just
all the
enough to
kids
know.
are getting seen by the pediatrician. That's a main issue because well, baby clinic are run mainly by in our side uh, by the general practitioners as well as the ASHA workers, and all those people who have the facility like access to the pediatricians are very minimal. So, uh, so yeah, it's a first step. Those who are accessing pediatricians help definitely can get the screening done. Uh, Definitely.
Yeah, or make it a rule there, whether it is an ASHA worker or a physician or a pediatrician, that these are the criterias, when you check the baby from head to foot, that eyes have to be involved.
Yes, yes, definitely. It's a first step. Coming together, AAP and Ophthalmological Association, putting forward advocacy. And it's I think better state would be Kerala because already there's an infrastructure that's there in the periphery to start with and make a model and
Yeah,
yeah, spread it elsewhere.
let's do that, Dr.
Yeah,
Jitin.
sure.
Yeah, thank you so much. Thank you
Yeah,
so
thank
much.
you.
I think Dr. Aarti wants to make a point. She has raised the hand.
Ma'am, I just wanted to say actually that's a very valid thing that you have raised. We have the national immunization schedule, which is printed and it is with every child. It is entered by ASHA workers or Anganwadi workers who just have to tick after giving the vaccination. If we
Yeah.
can incorporate a column which says like at 6, 10, 14 weeks, 6 months, 9 months, 1 year, 15 to 18 months, if there is a column by the side where they just check pupil reflex or look for the white reflex. I don't think it's not possible. If the Anganwadi workers can actually learn immunization, which is more tough, which can have reactions, which require monitoring and skill for administration, I think looking at an eye reflex is not something that is impossible. Like you rightly mentioned, if we can probably take one small taluk or district somewhere, train people and show a difference that we've been able to pick up so many number of asymptomatic cases in early phase, which will create an impact in their outcomes. I think then we will be able to convince the government or the higher authorities to incorporate this column. But first, we have to show that it will be possible. Like it's a simple test and that we can do it just by screening. We don't need any hi-fi instrument. They don't need to invest. Like primarily people are concerned about that. They don't need to invest monetarily to get this outcome. I think that way we will be able to definitely do a justice towards ensuring that they can also screen. I think it's definitely possible, ma'am.
Yeah, thank you, Arti. Thank you for being so optimistic about it. And I think in Karnataka, we should also get into this, space of trying to implement this. That will be a great contribution, in fact, to detect it very, very early.
Yeah, I think we'll go on to the next topic. The topic is retinoblastoma is curable by Dr. Fairuz. She's an ocular oncologist, a retinoblastoma specialist at Hora Specialty Eye Care and also associated with Site Care Hospitals in Bangalore. Over to you, ma'am.
Yeah, thank you, Shafali. Thanks for the introduction. I'll share my slides. Just a second. My slides are visible?
Yes.
Yes.
Yeah. Yeah, so well, I'll take you through, and as retinoblastoma is concerned, the positive thing about retinoblastoma is it's a curable eye cancer. I'm sure the panelist and the pediatric oncologist who we have here would definitely agree with me regarding this. So, well, these are the team of people who is involved in treating one single child, and I'm extremely grateful to it. And I'm really, really appreciate the support and contribution of all the organization that I'm part of, and especially thanks to Iksha Foundation and Humanist for supporting all these children, and of course, patients and parents who have always had the trust on us and stood with us, and every child is precious for us. So basically, when we talk about the management aspect of retinoblastoma, we have three goals. And the primary goal is always to save life. When it comes to cancer, cancer can lead to death. And retinoblastoma as a cancer, if it is advanced, can be deadly as well, as curable it is if we detect and treat appropriately. Now, when it comes to eyes, when compared to other organs having a cancer, eyes are very delicate, and it's a tumor which is filling the eye, where we as specialists put in a lot of effort with various different kind of treatment modalities to save the eyes as much as possible. And we all understand, we have parents here in this panel where for whom saving an eye of the child is the most precious thing to do, and this is what they expect from us when they bring in a child with a retinoblastoma. And of course, if we can save the eye, our tertiary goal is always to save vision. Now, taking you to one story here, this was a child, with bilateral retinoblastoma. You can see, in fact, white reflex in both the eyes. And there is a large eye, which is a right eye, which we call as ophthalmos because of a large tumor and causing increase in the pressure in the eye. So this is a scenario where we have an advanced intraocular tumor in both the eyes, where there is definitely an intent from our side to save both the eyes if possible. But when looking at the right eye, it's very, very difficult to save that eye because the pressures are high and it's completely blind. Now, this is how retinoblastoma looks like. This was his right eye, where you can see the eye is already bigger. There is a large tumor inside, and the left was equally bad. But we didn't give up. We went ahead giving chemotherapy for him. We had a positive stroke in this child, at least to save one eye so that he can lead a life, with a good quality of life. And well, we succeeded. So we saw him way back, when he was 11 months, and that was 3 years back when he came to us. And we saw him 2 weeks back, where we could save his left eye, which is this big. In fact, with lots of vitreous seeds, etc., we had to take off the right eye, which is an artificial eye, and he came in with his parent, with his newborn sibling, for a screening. So, well, this child is overall doing well, despite that the tumor was very, very large. Now, when I was showing you the picture of how retinoblastoma looks like, let me show how a normal eye looks like. So we have this eye when we look through indirect ophthalmoscope as a practitioner. This is the optic nerve, and this is the fovea, which is a central vision over here. Optic nerve is very, very important for us because any tumor sitting on the nerve is connected to the brain, and they can be a spread to the brain. Now, why is this area, this central area, important? Because if the retinoblastoma is sitting here in and around there, if we don't shrink it properly, the vision of the child can be compromised. Now, how does retinoblastoma look like? This is how it looks like. So in that empty space, when a white tumor grows like this is what retinoblastoma looks like. So this is a tumor which is very, very close to the nerve and also obscuring the vision area of the child. So these are the complexities which we as specialists deal with day to day when we are trying to save the life, when it's closer to the nerve, when we try to save the eye and vision of the children. And this comes in different variety and different types. And believe me, every child and every eye presentation is different. It's never the same. So going on to few, before and after scenarios, because we don't have too much time to, discuss the treatment in detail. This is a right eye of the child who was referred again, which is filled with retinoblastoma. And this is how the eye looks like. Now you can correlate how a normal eye looks like and the retinoblastoma eye. And we in fact succeeded with chemotherapy, with intravitreal injection, because she had lots of seeds. They can be spitting of seeds. Dr. Shafali has shown you that, and laser therapy, and this is how the tumor regressed. Now, yet another child here. This is her right eye, where the tumor is filling the entire globe. We cannot see the nerve, we cannot see the retina, nothing is visible over here. And this is like the seeds which the tumor is spitting over here. We didn't give up still. So we gave systemic chemotherapy, we have periocular topotecan, intravitreal topotecan, and the patient also received a focal, localized, targeted radiotherapy, which is called the plaque brachytherapy with the ruthenium plaque in this eye. And this is finally how we got the eye. The central vision was spared, and also the nerve was spared, and the child had 6/6 vision. Then we come to the other modality of primary treatment, that is intra-arterial chemotherapy, where we inject chemotherapeutic agents via the specific selective artery that supplies blood vessels to the eye. And through that artery, we actually give a targeted injection of the chemotherapeutic agents where it would directly reach the eye and treat the eye. And this is the before and after 3 sessions of intra-arterial chemotherapy. I'll come to the advantage and disadvantage of each later. Again, another case which had a large tumor. This is a group D eyes, where the complete tumor regressed with intraarterial chemotherapy after 4 sessions of treatment. So eye preservation as a treatment strategy in retinoblastoma, yes, we have various treatment armamentarium at this point of time, and it has advanced and leaped many steps ahead with focal treatment and focal consolidation. So basically we treat with systemic chemotherapy, intraarterial chemotherapy. Intraocular chemotherapy is an adjuvant if we have to treat the residual tumors. Then we have laser, cryo, and plaque radiotherapy, as I already mentioned. Now, when we talk about the 2 primary management modalities in preserving the eye and not taking out the eyeball, there is certain differences, good things about certain systemic chemotherapy and good things about intraarterial chemotherapy. Now, what we find is the final outcome in group D eyes, where it's slightly advanced with lots of seeds along with the tumor inside the eye, where with intraarterial chemotherapy, we find more eyes being saved, like around 85 to 94% of the eyes being saved when compared to 47% in systemic chemotherapy. Now, when we talk about, the not so good things about each is that systemic chemotherapy has excellent outcome, but as far as life salvage is concerned, eye salvage and vision salvage is concerned, but then it has systemic side effects, which we will come to later as far as discussion is concerned. But intraarterial chemotherapy has certain downsides. One, it is very expensive for a population from a low-income country like India to afford. Second, if it goes wrong, it can have severe complication in the eyes where the child can land up with blind eye even if you try to save the eye. When the vision is a concern in saving the eye, then intraarterial chemotherapy is slightly risky for these children. And it doesn't go into the system when it's an advanced group of retinoblastoma where we are worried about the tumor spreading to the body. Intraarterial chemotherapy doesn't have any effect because it's only targeted to the eyes. Now, when we talk about enucleation, that is removal of the eyeball, yes, there are situations where we as treating retinoblastoma surgeons also hesitate to go forward with any treatment because this is really advanced and there is no point, where the eyes can be saved. But yes, as a treating ocular oncologist and an oculoplastic surgeon, we are very, very concerned about the cosmetic outlook of this patient. First of all, it's very traumatic for a parent to know that the eyes are going to be removed. So then there is a discussion and, guarantee that we give the parents that do not worry, the eyes anyway is blind. Let us give you a very good excellent cosmesis where people will not be able to identify that the eyeball is missing, and in fact you will not know which eye has been taken, removed in this picture. This is the left eye of the child which has been removed because of a advanced intraocular retinoblastoma. Now, there are situations where, although we know that this eye might have to be enucleated, we still go ahead trying our best to save the eyes, because this is a child where one eye is already gone, has been removed. Now we are trying our best to save at least one eye, where we have done so many procedures in this child to save this right eye: systemic chemotherapy, 15 cycles, plaque brachytherapy, cryotherapy, intravitreal chemotherapy, intracameral. Intracameral is where we inject in the anterior space of the eye. He had to undergo cataract surgery because he had complications and side effects of the radiation therapy that he underwent. And unfortunately, after doing everything, when things settled, he came back to us where he was playing with wooden stick with his friends. He injured the same eye, the only eye that he had, and then he had a retinal detachment, and that was again done, and finally we could still restore his eye and vision in that eye. So it's not an easy journey, because things can happen even in the journey of these children. Whenever there is an extraocular extension, well, it's tough. It also depends about whether, when there is a high risk of these tumors spreading to other part of the body, be it the brain or the blood or the system of the child, we still try our best with the recent intensive multimodal treatment protocol, which Dr. Sunil will be talking about, to try to save the life of this child. And of course, this was how the child presented initially, and finally he's went home, he was from abroad, which was referred with chemotherapy and radiotherapy, saving his life finally. So my take-home message in this small talk over here is retinoblastoma is definitely a curable eye cancer. We can vouch that it is more than 98% curable, and we as a team of specialists, including the pediatric oncologist who plays a major role, ocular oncologist, radiation oncologist, the interventional neuroradiologist for arterial chemotherapy, the geneticist and pathologist, should always try to close the care gap. We have to make it accessible, available, and affordable for these children to live a very healthy and productive life and be the future of our world. Thank you so much.
Thank you so much, Dr. Feroz, for taking us through the treatment strategies that we use in these children. And of course, thank you so much for showing that no matter what the scenario is, in every scenario, there's a hope with the advances in the treatment that we have in our hands. Yeah, I'll go on to the next talk, and then we'll have a question with the panelists. Our next speaker is Dr. Sunil Bhatt. He'll be talking on life-saving treatment in advanced retinoblastoma. Dr. Sunil is the head of the Pediatric Hematology Oncology Unit and the Bone Marrow Transplant and Clinical Immunology Unit in Mazumdar Shaw Cancer Center. His expertise is world recognized, and we have the pleasure of having him here. Welcome, sir, and over to you.
So good evening, everyone. And first of all, thank you, the Horus team, I would say, both yourself and Feruz, for having us all here today. And I have to confess that I think most of the things I would have spoken had already been spoken already. So I'll be probably more of doing a summarizing act of all the three previous talks which have been done, and I think they were all great, crisp, and to the point talks. So I will be just touching on some of the medical treatment aspects of retinoblastoma, and I think we just discussed it already that we are the retinoblastoma capital of the world, with estimated 8,000 children born, diagnosed with retinoblastoma all over the world. But as was already mentioned, that we form the majority of it, and we're the largest retinoblastoma burden in the world. This will be discussed a little bit later, that retinoblastomas can be unifocal, multifocal. It can be unilateral, bilateral, Again, it could be sporadic or familiar, and hereditary or non-hereditary. And this again, there's a session on that, and we'll discuss some of these aspects in that session. What's very important to know is that I call retinoblastoma extremely funny tumor, because it's very unlike other malignancies which you come across in children. Why so? Because although it's a highly malignant, rapidly progressing tumor, and if we don't treat it, most of the times it will destroy the globe and the eye within almost 6 months. Although there are variations to it, metastasis can happen. It's not very common. I think it was shown in the, especially in the developed world, metastasis is very uncommon. But in our part of the world, we do see around 9-10% people present metastasis. Why I said it's funny? Because if the tumor is within the eye, the as Feroz also showed in her presentation, is that the cure rates are more than 95%. And in fact, we don't see anyone dying of retinoblastoma if it's an intraocular tumor and treated appropriately with the available treatment options. But as soon as it kind of spreads out of the eye, the metastasis, what we call it, whether it's local or widespread metastasis, it becomes extremely difficult disease to treat. And that's what we're going to be discussing a little bit in my 5 to 10 minutes presentation. So yes, it is a intraocular tumor and stays intraocular most of the times, especially if detected early. But there can be spread out of the eye, and we do have local tumor spread, which can happen. We also have a subarachnoid space of optic nerve can be a mode of spread, and that can lead to CSF dissemination and brain and spine spread. It can go through the anterior chamber, and through that, lymphatic dissemination is kind of very common. And we also have the hematogenous spread, which can happen, and it can lead us to the bone marrow or lymphatic invasion through that spread as well. So it can spread, and these are the various modes of spread, from the eye into the metastatic sites. Now, you know the diagnosis, which has been already been discussed, and this is again one of the very unique tumors where we do not need any pathology for confirmation. Examination or anesthesia is good enough for diagnosing a retinoblastoma. And that's also important not only for diagnosis but also for the characterization as well as the staging of the tumor, which we're going to discuss next. It was also already discussed in great detail that MR is a diagnostic of choice to look at the local spread of the tumor, and as well as spread into the brain and spinal cord. And it has got an advantage over CT scan for better resolution, as well as absence of radiation exposure, what we expect in a CT scan. So we may require additional staging biopsies, especially in more advanced tumors like bone marrow and CSF examination for the staging of it. Now, coming a couple of slides on the staging, the current staging which is followed is the international classification of retinoblastoma. It's very important. I think it is again, Shefali did mention it in a talk, and that's intraocular tumor which is confined to the globe, is classified from A to E, depending on the extent, and E being the most extensive disease, and A being the least one. And there are definitely criteria for that. I won't go to details of that. And there's some examples of the different stages, intraocular stages, which again Shefali had showed in her presentation. Now, what about staging when the tumor is outside the globe as well? So if it's eye is completely enucleated and is completely resected, there is no residual tumor left. We call it stage 1, and then stage 2 will have a microsomal residue. Stage 3 is regional metastasis, either orbital disease or lymph node metastasis, which is usually preauricular or cervical node. And if you have a metastatic disease, if it's A means without CNS involvement and B is with CNS involvement, and that kind of is not a good news, and we want to stage these tumors appropriately, whether it's intraocular staging as well as extraocular staging, so that we can give them the appropriate treatment which is required. And what are the prognostic factors? What are the scenarios where we get little worried about the tumor may not do as well as we expect it to. And some of the things which we know at this point of time, if there's an optic nerve invasion, if there's a choroid invasion, which is massive, if it's an anterior chamber invasion, which was, I think, a picture was shown by Feroz also, if it's a large vitreous seeding, if it's glaucoma, and if there's extraocular orbital extension metastasis, if there's a tumor which is called as triretinal tumor, which has pinealoblastoma associated with it. These are not good news, and these definitely make the treatment more difficult and outcomes poor. So how do we treat now? So treatment has been already been discussed. It's a multimodality treatment, and I think the best example of a tumor being managed by different teams, and there has been very close coordination, collaboration, and hence I think we are here with very esteemed ocular oncologist, because this is something which is treated as, and none of us individually can do justice to these tumors if we kind of look after them in silos. So the goal of the treatment, which has been already been again discussed, is we want to save. That is, first goal is to save patients' life, and I think this is very important for us oncologists as well to keep on reminding ourselves, because as Feroz mentioned, there's a huge psychosocial, psycho-emotional, association to these tumors. So it's very important to keep on reminding ourselves at difficult times that we need to, save the patient's life, which is utmost important. And then comes, attempt to save the vision. And of course, we also need to, especially from the medical oncology point of view, we need to decrease the risk of late sequelae from treatment, and also subsequent or secondary neoplasms. Now, again, Feroz did this already, but just to kind of put it again here is that we may have a surgical option, is enucleation, a local treatment which is delivered by ocular oncologists, and systemic chemotherapy, which I'm going to talk a little bit more. We can have intraocular chemotherapy, which was again showed intravitreal or the subconjunctival chemotherapy, and sometimes we may have to resort to radiation therapy, which can be external beam radiation therapy or brachytherapy. Brachytherapy examples are the plaque therapies, which are given very, very localized to the tumor wherever it's possible. Now, coming in the next 2-3 minutes on the chemotherapy aspects of retinoblastoma, which is a very important tool for helping us to cure these children with retinoblastomas. And it was very early in 1950s, it was realized that we can, treat these children with retinoblastoma with chemotherapy, and it does have a good, response rates, and hence it became, a standard of care, in the decades to follow. Now, chemotherapy in retinoblastoma is given in two different scenarios. One is neoadjuvant. Neoadjuvant is giving chemotherapy before the definitive treatment, which is in most of the cases in retinoblastoma is surgery, and that's enucleation. So we can deliver chemotherapy before that, and the idea of that is to reduce the size of the tumor. And if you are enucleating it, sometimes to reduce the size and make it more amenable for surgery, or sometimes when it's given along with the local therapies, which were shown to make them more effective. And these kind of two treatments work in tandem, and help the child to get rid of the tumor, trying to save the eye. But the other one is adjuvant chemotherapy. Adjuvant chemotherapy is once you have had a surgery done, an enucleation done, where you may or may not require chemotherapy post that. But what are the situations where you would give them a chemotherapy post enucleation? That would be if there's a high risk feature. High risk feature is in kind of layman languages, where there's a high risk of this tumor having invaded the surrounding structures, and there's a high risk of metastasis or spread. And there's some of the parameters which are listed here. I don't know the details of those, but if some of these high risk features are there after enucleation, we want to give them adjuvant chemotherapy post the surgery. Various drugs have been used, and some of them are listed here. A lot of drugs have been tried, but the most commoner one, or the most prevalent one, is the what we call as a VEC chemotherapy, vincristine, etoposide, and carboplatin chemotherapy. And there have been studies after studies, and the data, which is very robust and long term. The use of this, and this kind of started in 90s as a preferred treatment option for these tumors in the pediatric oncology practice. This chemotherapy is, as I said earlier, combined with adjuvant therapies, which is intraocular therapies, along with our ocular oncology friends, and they would give the local therapies which are lasers and things like that. And what has been shown is that the this using this combination of the external the local therapies and chemotherapies, you are able to manage ocular salvage and majority of the intraocular tumors, especially the ones which belong to, as has been shown here, to the I would say ABC group, and most of the D groups, and although intraocular tumors we would urge towards doing enucleation, but we do, as Firoz had shown a couple of examples, we do sometimes attempt ocular salvage even in the E tumors, in certain situations, especially if there's a bilateral retinoblastoma. Now, this is the standard VC regimen, which is commonly being used, and I won't go into the details, but there have been other, treatment protocols which have been looked at, compared, but this still stands out to be the most preferred option for the intraocular tumors as the chemotherapy option. Now, what about extraocular retinoblastoma? As I said, it's a funny tumor. As soon as retinoblastoma comes out of the globe and spreads out of the globe, it becomes extremely difficult to manage the children. The treatments become more complex, more, I would say, more toxic, and outcomes, are of course affected. So this, to refresh again what we discussed earlier, the staging, and we are now going to talk about stage 2, 3, and 4. If it's stage 2 and 3, which is the microscopic residue or a local spread, either to the orbit or to the or local regional lymph nodes. Here, conventional chemotherapy with external beam radiation becomes the kind of the standard of treatment. But what's reassuring here is that with the chemotherapy protocols, and there have been few protocols which have been tried by different groups, and I have showed a couple of examples here. Along with external beam radiation, even in this metastatic group, and this was data from almost a decade ago, you could still achieve around 84-85% event-free survival. And these are of course stage 2 and stage 3 extraocular retinoblastomas. Now, stage 4 and stage B, if 4A and B, which are metastatic, disease, where in A, you have non-CNS metastasis, and B, you have a CNS metastasis. This kind of used to be considered as the death warrants, and they still are very difficult, with very limited curative options. But what has been shown has evolved in the last decade or so, that you can still manage to treat and cure a good proportion of them. And this was a study where, out of 14 children which had, a bilateral retinoblastoma, which was quite advanced, 9 patients received what we call as autologous stem cell transplantation, or high dose chemotherapy with stem cell rescue, and also some of them received external beam radiation. And what was shown in that study is that you could salvage these patients with this treatment option. And this has been again published as a high dose chemotherapy from a North American group, where they use autologous stem cell transplantation for patients with 4B retinoblastoma, which is the most difficult one to treat. The 4Bs with the CNS metastasis, the outcomes are extremely poor. But in this series, what they showed is that some of the patients, I think it was almost 25-30% outcomes they could achieve with giving autologous stem cell transplantation, even in this difficult stage group. And this is again tried at retinoblastoma, where you have a pineal gland tumor associated with bilateral retinoblastomas. They are extremely poor prognosis, difficult to treat. Again, some data from the same group from the North America, where they use the same high dose chemotherapy, and there was 5 patients out of them who had 5 out of 9 who had event-free survival using this treatment strategy. Now, what is the kind of current standard, or current where is the world currently at dealing with these extraocular retinoblastoma? So this is the COG protocol, which I think we also follow at our center for extraocular retinoblastomas. There is a little bit high intense chemotherapy as compared to VEC, which is given as induction chemotherapy based on cisplatin cyclophosphamide etoposide, and it's repeated every 3 weekly, and we give about 4 cycles of that. In stage 2 and stage 3 disease, we would follow it by external beam radiation, but if we have a stage 4A or stage 4 disease, they will proceed with this high dose chemotherapy in autologous stem cell transplantation, which was shown in the previous slide. And we have got kind of preferred conditioning agents which are used for transplant. Carboplatin and thiative was very effective against retinoblastomas, and followed by stem cell transplant after that has been given. So this is currently what is kind of being practiced by the COG, and we follow here as well. Stage 2, stage 3, 4 induction cycles followed by external beam radiation, and 4A, 4B, again induction followed by autologous transplantation, and if required, external beam radiation for the 4A, 4B as well for the local regional spreads. So newer treatment modalities have been discussed. I won't go into details of those, and these are mostly very exciting. Is intra-arterial chemotherapy we do at our center, but I think there were some the concerns are of cost usually, and the technique of the operator, which has been already discussed. But there's also an interesting modality of treatment, especially when you try to salvage the group D eyes. And as Feru showed, the outcomes of the group D eyes with intraocular chemotherapy are better, and you can salvage a majority of these patients with this treatment modality. So to conclude, a very satisfying disease to treat. If it's a intraocular disease which is limited, maybe from A to D is quite satisfying. You can cure more than 95% of the patients, and almost 100% with A, B, and C. That's why early detection is very, very important, and treating them with a multi-disciplinary team, which includes various people who are on the panel, for example, today, is very, very important. But spread out of the eye, although it's not ideal, it's not what we want, but then there's still a ray of hope. So I think we should not deny any treatment for the children, even if there's an extraocular spread in the orbit, in the regional lymph nodes. We can still achieve 85 to 90% cure rates if they are treated appropriately with the treatment modalities which we have. And there are, although metastatic disease still a little gloomy, but there are some, some hopes there, with especially with the use of autologous stem cell transplantation as a treatment option, and you can salvage at least a few of those who may have even advanced disease which is metastatic, especially non-CNS metastasis. So with that, I thank you for the attention, and of course we can discuss any questions which arise. Thank you very much, Feroz, again, and for having me.
Thank you, Dr. Sunil, for being with us and sharing your knowledge and experience. Shifali, we can have Dr. Aarti for the discussion.
Yes, so we have another expert consultant pediatric hemato-oncologist and BMT specialist with us from one of the largest cancer centers in Bangalore, that is Sri Shankara Cancer Hospital. Welcome, Dr. Aarti, again, and thank you for joining us. I have a question for you. We have spoken so much about chemotherapy, and we know we routinely give systemic chemotherapy to kids with retinoblastoma, and there are 6 cycles every month, every 3 weeks, and there might be more cycles that might be required for them if there's a recurrence. parents. So the question is about the safety of this chemotherapy. How safe is the chemotherapy and how our children cope with it? Not just physically, of course, I would want you to tell us and the audience about the physical aspect of it, but also psychologically when they are going through the cycles every month. We know chemo is a toxic drug, and we have seen even adults not tolerating it well. So how do our children tolerate it physically, psychologically, and also the long term effect, because that is a very important question parents ask us, whether it will affect them in the future. So over to you for that.
Thank you for the opportunity, ma'am. So going to the first thing, like it's a myth that children don't tolerate chemotherapy well. So we always assume like adults don't tolerate, so how will the child tolerate? But we always have to understand that their organs are fresh. They are not having the comorbidities of hypertension, diabetes, heart disease. So usually the major problems that we see in adults, it's completely different when it comes to pediatric oncology. So pediatric oncology, most tumors are curable and like very nicely highlighted. I think retinoblastoma is one tumor where we can say there's going to be no mortality if it is intraocular, neither because of the disease nor because of the chemotherapy. Because the chemotherapy that we will be administering for retinoblastoma is very doable, very less toxic, and very easily manageable. So many centers even practice daycare chemotherapy because the vincristine, etoposide, carboplatin, the three drugs which are most commonly used, like in all the case of intraocular tumors and even in extraocular, we tend to use the same, just at a higher dose, etoposide. So they can be administered even on a daycare basis without much issues of hydration or without issues of inability to control nausea. So the common side effects that we will see will be constipation because of vincristine, which is very much highlighted, especially in the small kids, because we'll be using them in 3-month, 4-month-old, from every age group, it would be there. So constipation is one of the common side effects, but it is quite manageable. Apart from that, severe myelosuppression, which means fallen counts because of chemotherapy, or multiple episodes of fever, febrile neutropenia, which we call, are very unusual with this chemotherapy. So many times we tend to give them chemotherapy, tend them to just come back to us after 3 weeks, and it is very doable. But always we offer them chemotherapy in our center on IP basis only, and we make them stay at least for the first chemotherapy so that we can get a hold of how the child is responding to treatment and also how compliant the parents are. It's basically for us to develop a bond, develop an assessment as to how well they can assess if the child is getting sick and how easily they can get back to us. And subsequently, if they are doing fine, they can just come once in a month, and that is absolutely doable. The next thing about psychological aspect. So that is one of the most important as well as most challenging things when it comes to diagnosing and breaking the news to parents. Because when we first tell them like your child's eye needs to be removed, even if that is what has to be done, we find parents doctor shopping. This does not happen just with the uneducated lot or people who don't understand information. It happens very much even among parents who are really educated. So because it's very difficult for anybody to accept that at one go. So usually what we tell them is we do give them the information about the stage and what might be the response to chemotherapy as we slowly prime them, but we always start with neoadjuvant chemotherapy. So once they see, the doctor, the environment, and how we interact with them, how many times we see them in a day, they slowly try to understand and they start trusting us. I think that process is very important before we just go and tell on their face that we're going to remove the eye, because I think that's completely unacceptable. If we put ourselves in their position, it would just not be acceptable at all. So when we do that, they slowly come to an understanding, and we have multiple sessions with the parents trying to give them the exact picture. We don't overload them with information because many times it's dangerous than useful. So what they have to know, what can be the various possibilities, and the important fact that everything subsequently will depend on how the child is responding to treatment. I think when we tell them that, they slowly understand that it's not in our control, it's not in their control also. So over time, they develop some kind of trust, and they, they blend with the process and the scheduled treatment. So psychological aspect is something that is very important, should never be ignored, not for any other tumor as well. And like all of us here, I think pediatric specialty 50% of our time goes in counseling, just explaining to the parents what is happening, what we are doing. Because it's a very sensitive field, and that's how we are trained right from the beginning when we start handling children. The same holds true for retinoblastoma as well, and I think that should never be ignored, and it's very important.
Yeah, thank you so much, Dr. Aarti, for highlighting all those points. I'll move on to the next talk, which is by Dr. Ridya H. She's an assistant professor of Ocular Oncology Unit at the Malabar Cancer Center in Tellicherry, Kerala. And she'll be talking to us about retinoblastoma being a genetic disease. Over to you, Dr. Ridya.
Thank you. Good evening, everyone. Thank you, ma'am, for this opportunity. Am I audible?
Yes.
Okay. So next topic is retinoblastoma is a genetic disease. So let's start with the story of Daddy A. Daddy A was diagnosed with bilateral retinoblastoma when he was 1.5 years old, and both his eyes were enucleated and irradiated in 1994. So that's how we used to treat retinoblastoma in the earlier years. So what you see here is the family chart, or what we call a pedigree chart. This is Daddy A, which means he is bilaterally affected with retinoblastoma. This is the father, this is the mother, and 2 brothers of Daddy A. So Daddy A, after treatment, was completely cured of retinoblastoma, and he was a survivor. He went well, got married, and they had baby A. They watched baby A grow. They watched him grow, and they captured every moment of him. So these are the gallery pics that the mother had when we saw the child. So unfortunately, the daddy could never see his child, and the mother never knew that a white reflex or a squint that you see here or that she saw in these pictures was not right for her child until somebody else urged her to show an ophthalmologist. So when we saw the child, we did an EUA and he was diagnosed with bilateral retinoblastoma. Sadly, every member in the family knew that the father had bilateral retinoblastoma, but none of them were aware that retinoblastoma is a genetic disease. Yes, retinoblastoma is a genetic disease, and the genetics of retinoblastoma have been known for years. As early as in 1971, Knudsen proposed the 2-hit hypothesis, wherein we know that we inherit one allele from the mother, one from the father. And for any cancer to occur, we need some change in the genes, which we call it as mutation. So as far as retinoblastoma is concerned, the change occurs in the tumor suppressor gene RB1. And for retinoblastoma to develop, we need 2 hits or 2 mutations. This is the first hit and the second hit, which leads to the formation of retinoblastoma. So these hits can occur anywhere. The second hit always occurs in the eye, that is in the retinal cells. The first hit can occur anywhere. It could be in the sperm of the father, in the ovum of the mother, or it could also be in the zygote or the embryo, which is the future baby. And these group contribute to the hereditary retinoblastoma, which accounts for 40% of the cases. That means the baby has the mutation in blood. The first mutation can also occur in the eye. That means the first hit and the second hit occurs in the eye. And that group contributes to the non-hereditary retinoblastoma, which accounts for 60% of the cases of retinoblastoma. Now coming back to the story of daddy and baby A. So we know the daddy had retinoblastoma, baby had retinoblastoma. That means it is running in family. It is a familial retinoblastoma. Rarely, only 10% of the hereditary retinoblastoma, we get to see family history of retinoblastoma. And where does the hit occur? Here, obviously, the father had the mutation which was passed on to the baby. So the first hit was present already. And the father has a 50% of chance of passing on to his offsprings or children. And baby A also has this mutation in blood, which means he also has a 50% chance of passing it on to the next generation. And baby A, we know, was diagnosed with bilateral retinoblastoma. Of this note, 90 to 95% of hereditary retinoblastoma are bilateral. Now, obviously, there will be a doubt that the grandparents are not affected. If you see the family tree, the grandparents are not affected, neither any of the siblings are affected. So actually, in fact, we need to trace the family tree to 3 generations back. So we asked in detail, and there the grandfather's brother had a daughter who was blind and she died in childhood, and the reason was not known. So it's always necessary to take a detailed family history. And here you see a form of low penetrance retinoblastoma, which means it may not present in every generation. Generations could be skipped. So a detailed family history is again important. Now, next is the story of baby Y. Baby Y's mother was a nurse who saw a white reflex in her child when she was 1.5 months, and she knew it was not normal. She immediately took her to an ophthalmologist, and she was referred to us, and we diagnosed her to have bilateral retinoblastoma. So, as any other child, I'm sorry. So we could initiate the treatment at just 2 months of age, and now she is 2.5 years completely cured of retinoblastoma. So, as in any other child, we did genetic testing, and she was found to be found to be positive for RB1 germline mutation, which means she has it in blood. So, it is a hereditary retinoblastoma. But you see, none of the above generations are affected. It's not black. Of note, I would like to say that only 10%, as I told, has family history of retinoblastoma. Rest 30% of the hereditary retinoblastomas are sporadic. So where does the hit occur? So neither the parent, the father, and the mother doesn't have the mutation. So it is in the embryo which the mutation occurs, and it is a de novo mutation, and she carries it in her blood, and she can pass it on to 50% of her children. Next is the story of baby D. Baby D was found to have a squint was noticed by the parents, and she was immediately taken, and a diagnosis of unilateral retinoblastoma was made. A genetic testing was done which showed no RB1 gene mutation, which means she doesn't have the mutation in her gene in her blood. So it is a form of non-hereditary retinoblastoma. And all non-hereditary retinoblastomas are unilateral. They have tumor in one eye, but all unilateral retinoblastomas are not non-hereditary. So where does the hit occur? As I told earlier, both the hits are in the eye, not in blood. So she has 0% chance to pass it on to the next generation. So we have already discussed that the majority are non-hereditary retinoblastomas. So what is the importance of knowing whether it is hereditary or non-hereditary? Hereditary retinoblastomas possess certain definite characteristics which we'll see in the subsequent slides. Number one, hereditary retinoblastoma children can harbor brain tumors. So here you see there are 2 tumors in each eye. There is 1 tumor here, 1 tumor in this other eye, and there is also a tumor in the brain. So they have 3 tumors, and that is what we call trilateral retinoblastoma. So they have 2 bilateral intraocular retinoblastoma along with a midline intracranial neuroblastic tumor, usually seen in the location of pineal gland or suprasellar. In this case, you see 2 tumors in eyes and 1 tumor in the pineal region and another tumor in the suprasellar region. So in total, they have 4 tumors. So they are tetralateral or quadrilateral retinoblastoma. These trilateral or tetralateral are seen in 3% of retinoblastoma, but the incidence increases in bilateral retinoblastoma and even more in familial retinoblastoma. So we need to screen them at regular intervals until the age of 5 years. Number 2, why hereditary retinoblastoma is important. So this is the story of baby Z. So baby Z began having multiple episodes of seizures, or what you call fits, at the age of 1 year. So he was taken to a neurologist and he was being evaluated. And surprisingly, when they took an MRI, they saw tumors in both the eyes. And that was when the diagnosis of retinoblastoma was made. And when we saw the child, he had already bilateral tumors along with which had already spread to the brain or the CSF. So important is that when you see the child, he is not just like any other child. He has typical features. Herein you can see a large head, hairy, prominent forehead, hairy eyebrows, widely spaced eyes, a broad nose, thin upper lip, and he has a prominent earlobule and extra nipple. So we did a genetic testing which clinched the diagnosis of 13q deletion syndrome. So 13q deletion syndrome is seen in 5 to 6% of retinoblastoma cases. What is important is the recognition of this syndrome in children without family history of retinoblastoma. That is even more important as it is a clear warning sign that indicates immediate ophthalmic examination. And this will help us to diagnose retinoblastoma even before they present or they present with any symptoms. And we can have better eye and vision salvage. Number 3, why hereditary retinoblastoma is important. So, does anyone know who he is? It's already written. This is Jeff Healey. So, he was a famous guitarist, Canadian guitarist. So, why am I showing him here is that he was diagnosed with bilateral retinoblastoma at the age of 1 year, and both his eyes were enucleated. At the age of 3 years, his father gave him a guitar, and you can see he developed a unique way of playing it in his lap, a guitar being played on lap. And he went on to become a great Canadian jazz guitarist, singer, and songwriter. He was a survivor. In fact, he was a successful survivor. So in 2008, Jeff Healey the newspaper reported him to die from cancer. And post his death, he was inducted into the Canada's Walk of Fame. And this is the family picture that you see. And this is his daughter, who did not have any retinoblastoma. And this is his son, Derek, who was diagnosed with retinoblastoma. So 2 lessons from this story. Retinoblastoma is genetic. It can run in families. So when you go back and see, the newspaper said he dies after a battle from a rare form of cancer, retinoblastoma. So if you see more, they say in 2007, a year earlier, he was diagnosed with cancerous tissue from his legs and both the lungs. So in fact, he was diagnosed with a soft tissue sarcoma in his legs, which had spread to his lungs, and that has caused his death. So lesson 2 from the story, retinoblastoma survivors are at risk of second cancers. So these cancers can be anything, anywhere in the body, and the most common ones are sarcomas. And most common among them is osteosarcoma, which is a bone tumor, followed by soft tissue sarcoma. They can also develop other cancers like melanoma, bladder, lung cancers, or even brain tumors. And as the age increases, they have increased risk of developing these second cancers. So they need lifelong surveillance. We need lifelong surveillance in retinoblastoma survivors, and any lump or a bump or bone pain should be immediately brought to a specialist in retinoblastoma survivors. Number 4, why hereditary retinoblastoma is important? Because they need genetic counseling. For that matter, any retinoblastoma at the time of diagnosis should be registered in a genetic clinic, and a detailed family history and a family pedigree, as I showed, should be done. And then they should be advised genetic testing, the main aim being to assess the risk for family members, siblings, offsprings, which will enable us for early detection and treatment of retinoblastoma. So we do have specific guidelines for screening these children at risk. When you don't have genetic testing done, how do you assess the risk? So these guidelines gives proper risk assessments. For example, this is a case of bilateral retinoblastoma, which has 50% of chance of being passed on to the next generation, and the siblings have again 2.5% chance of getting retinoblastoma. So based on this, based on this pre-test risk, we have specific guidelines based on the risk as well as the age by which we need to monitor every monthly or with increasing frequency when the age is lower down, and decreasing frequency when the age is higher. Now, suppose if the genetic testing is done and you know that there is a RB1 mutation in the blood.
Hi, Nitya, can I interrupt you? If we can wrap it up quickly,
Yeah.
that would be great, because we have 2 other speakers.
Yeah, sure. So, so next question is, can we test the baby before the baby is born? Definitely yes. So by this we can test by using prenatal genetic testing by amniocentesis or choriocentesis, by which you can identify if the baby has RB1 mutation, if the baby is at risk of developing retinoblastoma, and subsequently the parents can take a choice. Even before conceiving, you have pre-implantation genetic diagnosis by using in vitro fertilization. So this is again a prenatal testing was done in Jeff Healy, and he is a successful survivor. So I'd like to conclude by saying that retinoblastoma is a genetic disease, and with advances in genetic science, we can do much more than treat the disease. We can predict the disease, we can prevent the disease, and guide the families through it. Thank you.
Thank you so much, Dr. Hridaya. I know genetics is very confusing for all of us, but you summarize it very nicely. I'll move on to the next talk. It's from Diagnosis to Delivery, a hospital-based challenges in retinoblastoma by Mr. Amit Sharma. Mr. Amit Sharma is CIO and Head Partnerships and CSR at Site Care Hospitals in Bangalore. Over to you, sir.
Hi, Dr. Shifali. Am I audible?
Yes, sir, you are.
Yeah. Uh, I do understand that we have kind of overrun the time, so I don't want to waste too much of time. And fortunately, with the eminent speakers out there, most of the things, especially about diagnosis, has already been covered. So I'll just share maybe a couple of minutes in terms of the challenges which typically a hospital like us fails, or I would say even the dilemma that we face whenever we get a case of retinoblastoma, or even for that matter any pediatric cancer out there. So, as Dr. Feroz and some of the other doctors have mentioned, I think the initial or the basic challenge is the early detection, and even from before that is the awareness related to retinoblastoma. So, a hospital like us, I think, has taken some sort of an ownership in terms of trying to spread awareness about this entire issue, and for that, we actually take help from experts like you, Dr. Feroz, and many of the eminent oncologists who are already in the panel out there. So I think that's one part where a hospital like us has to deal. The second important thing, which Dr. Sunil specifically also mentioned, is about the importance of a multidisciplinary approach, because many of the hospitals who deal uh, with pediatric cancer or retinoblastoma in particular, they probably lack all the experts which are required to manage this complex disease. So I think again, it's a question of working in collaboration, where I think a doctor like Dr. Feroz, who comes into play because she's able to take along a lot of different stakeholders together and help in kind of stitching the alliance, where we are able to actually work together and work for the betterment of the kids in or parents in specific. And the last, or the second last, is about the challenges associated with finances, because as we understand, more than 90% of the cases who comes specifically for retinoblastoma, they come from background where it is very, very difficult to arrange for the finances. And this is not a one time or a two time transaction. It's a very long drawn battle. So I think the arrangement of finances again involves the community to come together. As you had mentioned, probably it requires a village to kind of to take care of a child out there. So again, hospital faces that challenge, and we are trying to kind of face these challenges again with support of a lot of stakeholders. Fortunately, at Site Care, we work with a lot of communities, a lot of schools and colleges, which is helping us in taking some bit of, I would say, care of these cases. We see quite a few cases as compared to many of the other hospitals out there, but I think the demand is huge. And the last is, I think, an importance of making people aware of the long-term follow-up, which is extremely important, because I'm not a doctor, but as far as I understand, the follow-up is extremely important, because the recurrence could be very bad, and the entire efforts go in vain if the recurrence occurs and if the patient is not on the follow-up. So these are, I would say, some of the challenges which I foresee from diagnosis till the delivery. And I think all of us who are part of this talk need to rack our brains, need to work together, need to reach out. And I've always felt, I think the world is full of like-minded people who really want to help out. It's just that we need to kind of reach out to them when we feel that. Thank you. That's my message.
Yeah, Thank you so much, Mr. Amit, for summarizing the challenges so well. And we know what an amazing work you with the SiteCare team is doing for overcoming these challenges. So thank you so much for that. I move on to the next talk by Mr. Arvind Sheshadri. The talk is on retinoblastoma support group, comfort during crisis. Mr. Arvind is the founder's trustee and treasurer of the Isha Foundation, who does wonderful work with the retinoblastoma kids here in Bangalore. Over to you, Mr. Arvind.
Hi, good evening, everyone. Um, Iksha Foundation has been in operation for the last 15 years, supporting only children with retinoblastoma. So being part of this call, listening to all your talks has been educational for me. I think you can never stop learning. I've worked with Sunil Bhatt, I've worked with Dr. Fairuz for quite a few years. So one of the things I think the big challenges that we have as an NGO is to get funds. And so when the CSR bill was passed maybe about 8-10 years ago, I think that helped us a lot. Large corporations like Ratnakar Bank and Bajaj Finserv had been supporting us. Again, some of these funding organizations say that our need is too small or our ticket size is too small, and that they would actually want something that is, 4 crores. Our budget is usually about 1 to 2 crores every year. And funding organizations will say it's not just, you can't have all the funding just from us. It has to be multiple people who fund you. So ticket size would have to be 10, 12 crores or something like that. Iksha Foundation, all three of us founder trustees have full-time jobs. So balancing out the thing that we enjoy doing, which is supporting these children, and also getting a paycheck for paying all our bills is something that we have to manage between us. But one of the things that's helped us a lot is the social media. The first time that one of my nieces put out a post on social media through her mother's page, that got traction. Someone whose uh, aunt had got retinoblastoma when he was growing up. He remembered that, and then he found that there's a direct connect for him, and he was one of the people who connected with the CSR team at his company, and they basically helped a lot in spreading awareness of it. And then that was our first CSR fund that we got. And then when we were talking about support system for patients, for new patients, for people who are going through the difficulties, it is always very difficult for a parent. Like a lot of you have mentioned in your presentations, they are from lower income background. So just making ends meet, where is the next meal going to come from, is one of their biggest questions. So if they have this painful experience of, just hearing the word cancer can be very difficult. What we've found is whatever a doctor says, whatever a NGO says is not as powerful as what another family who's gone through this can tell them. So several times at Narayan Netralaya, I remember that we would have multiple patients at the same day. And when we'd go and talk to one of the new patients, I used to do the due diligence going meeting parents. And so when we go meet a parent and try to explain to them, what the problem is and that things are curable, it is a very curable form of cancer. And then there's another family, another mom or a dad who's right there. And I say, just look at these people, they've been coming for the last 6 months, and the diagnosis has been done right, it's done at the right time, and so the treatment is being done right. The tumor is not spreading as much. We're able to eliminate it and things like that. I think hearing it from the other parents helped. So if doctors can plan multiple parents with different, levels of uh, RB treatment that the patients are going through, I think that might help. Just hearing it from another person who has gone through the same pain and is getting over it, I think has been one of the lessons that we have learned. Trying to connect people, talking to them on the phone is not the same as meeting them face to face. So, we've shared numbers with people. A lot of our patients' parents who've been supported by us have said that they'll do anything they need from us in order to be able to help another family go through this extremely difficult thing. So having, two, three things that I've talked about here, I'm just summarizing quickly. One is social media helps a lot. So it is for early detection. It is just for detection also. It is just for spreading awareness. Second thing is if it's another parent who can talk to a parent who's going through this for the first time, that also helps support a lot. So these are the two main takeaways that we've had, I think, in our 15 years that we've been associated with uh, RB, basically. Thank you.
Thank you, Arvind. Thank you so much. You have been very modest here and humble. Uh, the change that you have brought about, in many families and many children's, in supporting them during the crisis, as Shifali has put the topic rightly, has been enormous. Supporting them financially. So I also appreciate how your organization even tracks these patients when they're lost to follow up with the fear of abandonment of treatment. You have the system so robust that you are actually, I also remember certain children who are taken care of their education even post treatment. So that is the extent and depth to which you guys actually focus in taking care of these children, and that has been tremendous, incredible. Congratulations, and a long way to go. And I
Thank you.
think we
Quick
should
two
be
things.
we should
Quick,
be giving,
yeah.
no, Arvind, we should be giving 15 crores checks. We should not think small. And I think there are so many kids who need this, in future. We should
Yeah.
not limit us. I think
Yeah.
so.
Quick couple of things. One is, like you rightly said, the need for educational funding also came up when one of the parents said, yeah, it's great, you'll take care of my daughter, and she'll be cured of this cancer. Who's going to marry her? She becomes a burden for me as she grows up. She's going to have to be with me all her life. And that's when, we sat down as a team and said, I think we should do more than just giving them, saving their lives. If we can give them a way to earn their own livelihood, it'll help. So there's maybe about 40, 50 parents who have reached out to us, all the way from 15,000 rupees a year for a school fees for a child, um, to 60, 80,000 rupees a year. So that's where the education thing came in, I think. And just hearing about the fact that girl children are treated differently, it's unfortunate, and I think even one of the statistics showed that it was mainly male dominated here in India. So yeah, the education thing was one of the things that I think has also helped a lot in making sure that people come back, you're in touch with them, you get their report card once a year, how they're doing and things like that. That also helps us stay in touch with the children.
Thank you so much, Arvind, and equally thankful and grateful to Amit also, where it's not easy for a private, healthcare system to navigate in catering, the financial challenges that we face. And you also have been doing, a lot of initiatives, especially with the help of Humanist, who comes in as a team in various aspects in raising funds and being able to cater to the needs of these children financially and otherwise. Thank you so much, Amit, for having.
Thanks, Dr. Farooq. And as you said, the need is limitless. So let's try and work together. And I totally agree. There is
Yeah.
a huge, huge need, and hopefully we should be able to support more kids.
Yeah. Thank you. Thank you so much. So, well, we have Dr. Mohan Raj here. He's a consultant and specialist in pediatric oncology and BMT at Sidecare Hospital. So, it's a honor to have you here, Dr. Mohan Raj. So, why I really wanted here today for a discussion is like your experience from All India Institute of Medical Science, which is completely a public health system, and I'm sure delivering care to different strata of the society is a different ball game in public health system, and then you actually changed your pathway to a private health system. And I'm sure there would have been times of frustration, as we all do, when we have a patient walking from a very low socioeconomic status, how to cater to the, obviously quality is there everywhere, but when it comes to a private health system, we actually there is triple fold or tenfold in the quality of system, which doesn't come free, and there is a cost which is always associated to it. And there are government schemes which makes it easy in a public health system. And how did you navigate these challenges? You treat many other cancers, just not retinoblastoma, as a pediatric oncologist. So how did you navigate this journey? Dr. Mohanraj, you're muted. You're muted.
Am I audible, ma'am? Yeah. So I have worked in both the places. I have worked in government setups as well as, so I'm currently associated with Site Care, which is a private sector. So I think Amit has already answered this question because no. So at AIMS, no. So we used to see clinically, we used to see a lot of retinoblastoma. Retinoblastoma, as we know, is no, it's not a very common cancer, though it's a rare cancer in children. So because of a referral center, we used to see a lot of cases, and retinoblastoma is the second most common cancer we see at AIMS. So there is a huge load, and clinical presentation wise, there is a lot of cases who presented at a very advanced stage, and we have, as in a government setup, we have so many other support systems. We have can kits associated with us, and other government supply of medications. But coming here to a private setup, actually, I'm not facing any issue. We have so much support system at our hospital. Amit is just a call away. So whenever I am getting any unaffordable patient, so I'm grateful enough to associated with our amazing NGO, Humanist, which is not only supporting for retinoblastoma, and also we have some other support system. We have school children who used to raise fund for needy patients, as well as from the hospital side also. We are getting so many supports. With this support, I'm not at all facing any issue from the financial perspective. With this, almost we have supported so many children, especially with retinoblastoma. Fortunately, the cost of retinoblastoma treatment compared to other cancer treatment, it's relatively less. And with the full support system, we are now able to manage so many kids with retinoblastoma. So I'm not facing any issues from the financial perspective.
Thank you so much, Dr. Mohan Raj. And that's exactly why I wanted you to speak. So, how things, so there is an impression that patients have, sometimes when they come and see a setup, they really get scared also, despite the fact unknowingly that they don't know the fact that things will be taken care in the similar way as far as finance is concerned, even in private hospital, where the system really want to genuinely help these patients by whatever means they can do. So they get overwhelmed when they walk into a system which is like very different from a public health care system, and they're referred thinking that the treatment cost will be a huge burden to them, without knowing the fact that the system is working in a way which is going to accommodate them and make it affordable and accessible for them. Not even affordable, where the complete treatment is taken care by foundations. And this is how the healthcare system in India is catering, which is very, very different from different parts of the world. Where one of my a friend always says that there is some kind of a divinity in the population of India, where people really genuinely want to help, in different aspects. As you said, even school children taking care in, raising funds for these kids is a great, great initiative. So, which makes things a little bit easy for us, where the majority of the patient comes from a low income background. Yeah. Thank you so much, Dr. Mohan Raj, for this very positive, outlook towards your patients. Thank you so much. And well, we have our special guests here. We have our parents who have stood through the storm. We have Ms. Jayaprabha here, Mr. Kaviraj, and Ms. Deepika, who has been the strongest pillar, in going through this journey with us in our patients, and it'll be really nice to hear from them. You have, listened to us how we deal with the cancer, but then, it's completely different, where we also sit in their shoes and then try to understand what they go through, and it'll be very nice to hear from them. Shifali, would you like to? And welcome. Thank you so much for joining us. It's indeed a great pleasure to have you with us in this platform.
So I'll have my first question for Ms. Jayaprabha here. Just to start off the discussion with the parents. Your child got diagnosed with retinoblastoma. I would want you to explain to our audience what the family goes through when you have a child who gets a diagnosis of retinoblastoma. Can you share your experience with us? Your voice is not heard, Jayaprabha. No.
No, are you muted? You were audible from the
Yeah.
beginning. You were very active.
Mhm.
No.
Ma'am, could you change your headphones, please? Probably your headphones are not accepting it. You can speak over the laptop itself. I think yes.
Am I audible now?
Yes, ma'am.
Yeah, thank you so much. Yeah, when a child is diagnosed with cancer, like IR retinoblastoma, as a parent, like we really face a significant impact on our emotional, psychological, and social and economic well-being. So the diagnosis led us to like stress, anxiety, depression, and even physical health issues, as well as changes in the family lifestyle. And also like some parents also may experience guilt, feeling responsible for their child's illness, or struggling with the emotional burden of taking care of the child with cancer. Now, the diagnosis can alter the family relationships, leading to changes in communication, conflict, and emotional distance. So as we all know, the word cancer itself is very scary. So with the support and the motivation of our doctors has helped a lot in this journey. So my special thanks to Dr. Fairoz, Dr. Shifali, Dr. Arti, and Dr. Hrideya. Thank you so much for conducting this awareness webinar for retinoblastoma. Thank you. Thank you all.
Thank you so much, Ms. Jayaprabha. I know you have the cutest child, and I know how well you have taken care of her and of your entire family. So that was the question was to you, because you are such a family person. Your entire family is there for your support whenever there is visit to the clinic. So thank you.
Thank you.
My next question is to Ms. Veena. I hope you're there, Veena. Another one of our favorite. Every parent is favorite, but they have the cutest children, and we have the most fun with them when they visit our clinic. So to you, I would want to ask. So after all the treatment that your child has gone through, uh, and all the struggle that you have seen over the years, and he has undergone so many treatment in terms of chemotherapy, and in fact, the eye also could not be salvaged. So, do you think there has been an effect on his performance, basically in the school or in life in general? I know how active he is, so I just want you to tell to our audience how the journey has been for you and Manikya.
Can I answer it in Hindi, doctor?
Yes, go ahead.
नहीं, ऐसा तो कुछ नहीं है, लगता ही नहीं है कि उसको उससे कुछ हुआ था, कोई प्रॉब्लम था उसको करके। लेकिन अभी जो उसका एक्टिविटीज है, इससे तो ऐसा लगता है नहीं, मेरा बच्चा सब बच्चों के जैसे एकदम नॉर्मल है। कोई उसको ऐसा कुछ हुआ ही नहीं था। लाइक अभी 13 कीमो जो हुआ है, उसके बावजूद भी हर एक एक्टिविटीज में हो, या स्विमिंग, स्कूल का एजुकेशन हो, कोई भी स्कूल में कंपटीशन हो, हर एक में हिस्सा लेता है, हर एक में पार्टिसिपेट करता है, तो बहुत अच्छा लगता है मुझे। तब फील ही नहीं होता है कि हमारे बच्चे को कोई ऐसा प्रॉब्लम है रेटिनोब्लास्टोमा करके।
Yeah, I know. And and he always comes with his trophies. So we are also proud of him, and good job in taking care of him.
I think, Mama, it's always, parents plays a major role, the positive impact that you make on the child, taking things in a very optimistic way. I think that builds up how, in future they would do, you things, I'm sure you go through a lot of psychological, uh, um, I wouldn't call it as agony, but disturbance, when the treatment is going on. But then how positively you express towards the child, that is also really impactful, how the child goes ahead. Jaiprabha, Veena.
सॉरी डॉक्टर।
जैसे आप लेते हो ना, जब बच्चे को बीमारी होते हैं, आपके ऊपर
हाँ
भी थोड़ा इफेक्ट हो जाते हैं, लेकिन आप बिल्कुल पॉजिटिव तरीके से जो फैमिली को लीड करते हैं, बच्चे को आगे लीड करते हैं, वो भी उसके
हाँ
फ्यूचर में डेफिनेटली इम्पैक्ट करता है ना मम्मा?
हाँ, वो तो है ही डॉक्टर।
या
पहले हमको स्ट्रांग होना है इन
राइट।
सब बच्चों ऐसा बच्चे के सामने हमको दिखाना नहीं है कि हमारे बच्चे को कोई प्रॉब्लम है। वो हेल्थ के बारे में हो या किसी और चीज में ही हो, हमको ये नहीं दिखाना है कि बच्चे हमारे बच्चे को कुछ प्रॉब्लम है। जब हम हो गए तो हमारे बच्चों को हम शायद थोड़ा उनको भी थोड़ा स्ट्रांग कर सकते हैं। बस
राइट।
हमको स्ट्रांग रहना है और उसके बाद ही हम बच्चों को भी गाइड कर सकते हैं कि तुमको
राइट।
कुछ प्रॉब्लम है ही नहीं, तुम तो हर बच्चे जैसे नॉर्मल हो। और उसमें भी हमको ऐसे डॉक्टर्स जो इतने अच्छे डॉक्टर्स मिले हैं, हर एक बात में हो या ट्रीटमेंट में हो, किसी भी प्रॉब्लम हो, कुछ भी प्रॉब्लम लगता है तो हम डॉक्टर से डायरेक्टली बात कर सकते हैं, तो उसको वो सॉल्व करते हैं। तो ऐसा लगता है वो डॉक्टर नहीं है, जैसे हमारे बहुत पुराने फ्रेंड्स हैं हमारे, वो डॉक्टर के जैसे कभी ट्रीट किया ही नहीं, तो मुझे तो कभी फील हुआ ही नहीं कि डॉक्टर है। तो सिर्फ हम जैसे अभी हम नॉर्मली सबसे बात करते हैं, ऐसे ही उनसे भी बात करके वो उसके बारे में जो भी हमको पूछना होता है रेटिनोब्लास्टोमा के बारे में, तो डायरेक्टली हम पूछ लेते हैं, तो हर एक प्रॉब्लम का सोल्यूशन उनके पास है।
Anyway, we are so happy that all the kids are doing extremely well despite the initial, glitches that you had. Yeah. Thank you so much, Veenu. Thank you very much for coming
थैंक यू टू शिक्षा फाउंडेशन ऑल्सो डॉक्टर, एंड थैंक यू ऑल योर टीम डॉक्टर।
in. Thank you.
My last question is to Mr. Kaviraj here. Can you come on screen, Mr. Kaviraj?
Hi, ma'am.
Hi.
My God.
Is it okay?
Okay, hi.
Hello, Kaushik.
Say hello.
Hello.
Hi.
Ma'am, we are traveling, ma'am.
Thank you so much still for joining, Mr. Kaviraj. आपसे भी
Yes,
एक
ma'am.
क्वेश्चन है, या कि इतना ट्रीटमेंट रहा कौशिक का, एंड काफी सारा स्ट्रगल्स के थ्रू आप गए, एंड बट अल्टीमेटली डिसीजन हैड टू बी मेड, जो कि बहुत ही इंपॉर्टेंट डिसीजन था, टफ डिसीजन था, टू टेक आउट हिज आई बिकॉज द ट्यूमर हैड प्रोग्रेस। तो वो डिसीजन कितना डिफिकल्ट था आपके लिए, और कैसा रहा वो जर्नी? आप वो थोड़ा बता सकते हैं व्हेन इट कम्स टू कि हाँ इतना हो गया है कि निकालना पड़ेगा आई को, तो हाउ टफ वाज दैट डिसीजन फॉर यू एंड योर फैमिली?
फर्स्टली मैम, मैं ये बोलना चाहता हूँ कि हम तो बहुत कोशिश किया था। मैं फर्स्टली थैंकफुल फॉर फैरोज मैम, सुनील सर एंड अरविंद सर, इक्शा फाउंडेशन। फैरोज मैम ने तो हमारे कौशिक के लिए तो बहुत कोशिश किया है, वो आइज सेव करने के लिए। एक्चुअली इसका आई सेव करने के लिए हम करीब से 2 अढ़ाई साल तक बहुत कोशिश किया। टोटली मैम ने पहले से ही बोला था, उसका आंख में कुछ डिविजन नहीं है, फिर भी हम देखेंगे, उसको बचा सकता है तो करेंगे। लास्टली मैम वो क्या हो गया, हम उसका जो ट्यूमर है था आउट ऑफ आई से स्प्रेड होने के लिए बहुत एक्सपोज हो गया। फिर हम लोग सोच लिया, मैडम मैम ने बोला नहीं, इसको तो निकालना ही पड़ता है। मैम को कितना बार मैं ये रिक्वेस्ट करता था, मैं मैम उसका विषय नहीं है तो भी एक बाप होके, पेरेंट होके उसका कुछ नुकसान चाहने के लिए मैं नहीं रेडी हूँ। फिर बाद में हम ये भी सोचा कि अच्छा चलो, बच्चे की जिंदगी का फर्स्ट उसका जान का बहुत ये चाहिए था हम लोग को। चलो, इसका जान से तो ज्यादा कुछ नहीं है। अगर इसको आंख भी गए तो हम तो इसको बचा लेंगे किसी से हाल में। भगवान जो भी दिया है हम उसको एक्सेप्ट करना पड़ता है। उसके लिए हम मैम जो बोला है, मैम के इससे जो भी हमको कष्ट आया था उससे हिसाब से हम चला गए मैम। अभी तो मेरा बच्चा बहुत अच्छा है मैम. Actually, he had completed second standard. He had the A+, ma'am. He is very good now. इसको मेरे को ऐसा नहीं लगता है मैडम. इसका कुछ प्रॉब्लम है ऐसा नहीं. जो भी आया हम एक्सेप्ट किया है. जो एक्सेप्ट किया है हम उसी से हिसाब से जाएंगे. फर्स्टली इस वेबिनार से मैं सबको वो ये बोलना चाहता है, जो भी हमको कुछ कष्ट आता है वो कष्ट को एक परिहार होता है. वैद्य नारायण हरि बोलता है. सब हम डॉक्टर का जो बात है सुनना पड़ता है. वो सुन के हम आगे जाने से हमको अच्छा हो जाएगा. थैंक यू मैम.
Thank you, Kaviraj.
Yeah, this
से
thank
थैंक यू.
Thank you, ma'am.
Bye. Thank you so much. Yeah.
बाय बाय. से बाय.
Bye bye, ma'am.
Bye. 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 Yeah.
Yeah, this brings us to the end of this very informative and, in fact, I would say not just educative but awareness creating webinar by our extremely expert panelists and speakers. Any last word, Dr. Feroz, from you or from any other speaker?
Yeah.
I
May I
know it's
request
slightly
any
late.
other,
Yeah.
any other invited speaker, if you want to put in a word as a conclusion remark, and then we can end this.
No, I would just like to say, Dr. Farouz and everyone, you people are doing an amazing work, and just keep up kind of motivating all of us. We all know this won't be able to be addressed by one or two people out there. We need a huge, I would say, collective effort. So hopefully, sessions like this and more uh, of us coming together will help us in moving ahead. So thank you, everyone.
Thank you, Amit. Thanks a lot. So, from my side, I'm extremely grateful that, in the first go, all of you agreed to take part in this educative and awareness program. And I think we need a lot of awareness. As far as treatment is concerned, India is in par with the Western countries. We know what to do. We have all the facilities and the equipments available in India. And our outcomes has been again in par with Western countries, despite the fact that we see advanced cases as compared to other countries because of the lack of awareness. And most importantly, I think we all should work as a team. I always say that retinoblastoma treatment, it takes a village to take care of a child. It's just not an ocular oncologist or a pediatric oncologist. As you saw here, the entire ecosystem is a team of people which finally works in this journey to get a great outcome in these children for a brighter future. So awareness regarding the disease is something that we have to really, really propagate as a team, as a parent, and as a specialist, and as a public. And that's exactly why we wanted this webinar, just not specialists talking about the aspects of the disease, but the entire team coming through and listening to the parent, how they have gone through this. And I really wish that this creates some impact in some way as a public awareness to the disease, which is highly curable. Thank you so much for being with us. Thanks a lot.